Dr. Priyankar Pal is Professor and Head Pediatrics in the Institute of Child Health, Kolkata.
So, I hope everyone is back after the couple of days. So, we have a couple of speakers over here for the session, and I would request Dr. Rakesh Vilani to start this one. So, Dr. Rakesh Vilani to come to the dais. Rakesh, as you all know, is Assistant Professor of Pediatric Allergy Immunology in the he has extensive publications, more than 100 papers in peer-reviewed international journals. He has received research grants from ICMR, DSC, International, and key areas of interest being Kawasaki disease. So over to Rakesh. Next is Dr. Devdatta Mukhopadhyay. Devdatta is a pediatric cardiologist, very well known in pediatric cardiology circles. She is now the treasurer of the Indian Society of Kawasaki Disease. She is an associate professor of pediatrics in the Western University of Health Sciences and a consultant pediatric cardiology at Apollo Hospital, Kolkata. We have then Rishika, Dr. Rishika Mehta, who is also a pediatric cardiologist from Narayana Superspecialty Hospital, Howrah. And the fourth speaker will be Dr. Amber Kumar, additional professor of the Department of Pediatric Cardiology, Pediatric Unit, Department of Pediatric AIMS Bhopal. So he is also the secretary of IIT Bhopal. So over to Rakesh.
Thank you, sir. So in this over 30 minutes, along with 3 pediatric cardiologists, I am a pediatric rheumatologist. So firstly, I am starting because what are the expectations from the pediatric cardiologist, and how echocardiographies are what is the point of care echo, and why we have kept this as a point of care cardiovascular assessment in KED, because you must be learning that echocardiography in Kawasaki disease is not a one event. We have to do many times. That's why it's a point of care assessment. So Kawasaki disease, the heart of the matter is that matter of the heart, because it's a disease which causes the cardiovascular complications, and therefore we are having this long-term follow-up and cardiovascular management of this disease. So the manifestation of cardiac involvement include in acute phase, subacute phase, and chronic phase. Several things are there, that it's a disease which is possibly a pancarditis, which have a mitral regurgitation, tricuspid valvular regurgitation in form of mitral regurgitation, tricuspid regurgitation, and aortic regurgitation. Then myocardial dysfunctions and pericardial effusion, and coronary artery abnormalities, which can be seen as a perivascular inflammation, ectasia, or a full-blown coronary aneurysms. So in chronic phase, we see coronary arteries sequelae because of coronary artery aneurysms, and cardiovascular involvement is Kawasaki disease is a wide spectrum thing. It's not just coronary artery abnormality, which has been highlighted several times. So we all know American Heart Association scientific statement, and which provides the guidance for the cardiovascular for the diagnosis and management of Kawasaki disease. And in this scientific statement, there are guidance for the how to do cardiovascular assessment also. So for to coming straight to the topic, that goal of echocardiography in a Kawasaki disease. So the two most important goal is that basically echo is the primary imaging modality in a Kawasaki disease, and for all patients with Kawasaki disease, with the diagnosis of Kawasaki disease, echo is to determine the degree of cardiac involvement. It's not for diagnosis. That's what I'm saying, because diagnosis is still a clinical thing, and in incomplete Kawasaki disease, when you have incomplete features, there is a role of an echocardiography in a diagnosis. So if there are incomplete features and echocardiography is positive, that suggested this Kawasaki disease. Otherwise, the goal of echocardiography is that to know determine the degree of cardiac involvement. But the most important thing is that echo should not delay treatment, and we should not delay the treatment for a echo to happen actually. And second most important component during the acute phase is that echocardiography in Kawasaki disease during acute phase is a more of, it involves several things, like sedation is a very mostly required in very young children, especially in less than 3. We use typically triclophos, pedicloryl, which is to sedate, because during the acute phase the children will be irritable, and due to the fever there will be significant irritability, and to do echocardiography in young children is a very tedious job. So, and it sometimes may required in older children also, because during the fever there may be significant irritability. And initial studies is a baseline for longitudinal follow-up for coronary artery morphology, LV wall motion, valvular regurgitation, and pericardial effusion. And so the initial echo should be done in the first week of illness is typically normal, because you may not see coronary artery abnormalities or coronary artery abnormalities in less than 7 days. You may see a myocardial involvement or myocarditis typically in the first week of illness. So imaging standards, I'm sure that cardiologists would be talking about, but echocardiography should be performed with equipment with appropriate transducer and with an experienced pediatric echocardiographer, basically who has a dealing with the pediatric children's, because doing an echocardiography in children is more of like an art rather than science, because it's a patience, lot of patience is required, and sometimes you have to do for half an hour also in a young children, because children will take time. And the imaging should be performed with highest frequency transducer, and the probe allow these high transducer probe allow high resolution detailed evaluation for coronary artery abnormalities. And during the acute phase, the dynamic video or digital cine format should also be recorded, and the standard anatomic and physiological imaging will be dealt by the other speakers, and it should also focus on imaging the left main coronary artery, LAD, RC, and posterior descending coronary artery, and multiple imaging planes should be, so one coronary artery should be imaged in a multiple planes. It should not be taken in a one plane only. So these are the echocardiography views which has been given in the American Heart Association statement also. And the typical sites for coronary artery aneurysms are proximal LAD, proximal RCA, left main coronary arteries, and left circumflex. So typically in the sequence usually, and least often the junction between the RCA and posterior descending coronary artery. So the qualitative and quantitative assessments both are important, and measurement of coronary artery abnormality should be done in inner edge to inner edge, and they should not be measured at the bifurcation. And it should exclude pointing of branching, which may have normal focal dilatation, and absolute luminal dimension should be measured inner to inner edge. And we should also try to see whether these are secular aneurysms or fusiform aneurysms, because secular aneurysms have worse outcome with in the long run. So these are the coronary artery aneurysms of quantitative assessments, which as per the American Heart Association statement, G-score should be used in all patients. And the G-score system, the most important with G-score is that there will be talk about these things, there will be separate session, but most important is that we have to use single G-score systems over the time. We should not change the G-score system in different, because there are several G-scores are available. Similarly, in 2020 JCS guidelines also, they have also started using GCS, but as per JCS, the Japanese Ministry of Health, they are not still using G-score 2225 as a dilatation. But typically the typical definition of coronary artery aneurysms, which stands true possibly today also, because that large aneurysms are 8 mm in inner diameter, if it is more than equal to 8 mm is a giant aneurysms. And typically, if you see, the long-term complications are associated with aneurysms absolute diameters of more than 8 mm. So coronary artery involvement, another definition for coronary artery abnormalities are, if you see the diameter in like dilatation with an internal diameter of segment measuring less than 1.5 times that of an adjacent segment. So according to adjacent segment also you can define the coronary artery abnormalities. So coronary artery involvement, there should be jet score should be used, and the jet score should be continued, same jet score should be applied in several settings. So the cardiovascular assessment in a Kawasaki disease should not be limited to the coronary artery involvement, and it should go beyond that. That assessment of ventricular form and functions also should be looked, and assessment of aortic root, assessment of pericardial effusion and valvular regurgitations should also be. So these are the recommendations for cardiovascular assessment, which has I have already highlighted. So Dr. Debatatha will go further into this.
Thank you so much, Dr. Rakesh, for the wonderful presentation. A very good evening to respected chairperson, Professor Shudha, Professor Singh, and all the audience. Let me briefly touch upon the various aspects of point of care. Firstly, if the child comes, I would like to see whether the child is having any symptoms, whether there are any complaints of excessive crying or any other conditions there, and also check for the hemodynamic stability. And that will be discussed again by Dr. Ambar. And echocardiography, as discussed, forms the cornerstone. In that list, I would definitely add valvulitis. And of course, depending on the findings, we go for advanced imaging. Cardiac enzymes, biomarkers, and inflammatory markers are point of care tests, which would help in the supporting the diagnosis. And of course, in the long term, we would be asking for stress test, and including an ECG in the follow-up is very, very important. So with all this, I feel like I'm one of those 6 blind men who are trying to decipher the elephant. This is the holy grail of the whole thing, the various coronary arteries and their various views. And just to mention, when we take the pictures, we must increase the frame rate, reduce the sector width, reduce the depth, and for every measurement we should zoom on the focused area. Harmonics should be put on the lower side and increase the compression settings for better resolution, and of course use a higher frequency transducer. We have to look at the other views of the echo as well if we are missing any other things in the echo like valvulitis or function, assess the function, which I'll discuss, and also any thrombus. So we do have to put the color flow in the coronaries, because sometimes we may come across the pericardial sinuses, so those will not have any color flow in them, and we have to put the color flow in such an angle so that the beam is parallel to the course of the coronaries. Here it's demonstrated, and I would like to bring your focus to this bit, because sometimes if in an ideal setting the child is quiet or well sedated, this is the normal coronary flow. But if we have a high resting coronary velocities by the pulse Doppler, that indicates probability there is a stenotic lesion, and usually we put in the Nyquist limit 30 or below. This is the place where you can see the color flow velocities are very, very less to get the low flow velocities in the coronaries. And these are the other views these are the other views where you can see the LMCA coming out from the aorta and also the RCA. This is the apical 4-chamber view, and also the parasternal long axis view showing the RCA. It's slightly tilted forward. This is the pulmonary artery, and this is the right coronary artery. And this is the circumflex in the atrioventricular groove in the sort of the modified 4-chamber view. This is, I would just show you this. This is a child who had coronaries of all four of the coronaries were in quite enlarged, having giant aneurysms. And the upper 2 of a child we saw in December with large aneurysms of the LMCA and the LAD. And we are not measuring at the bifurcation. We are measuring end to end, somewhere in the middle, not at the origin, not at the bifurcation. So that's it. And that's the same child who had a thrombus. On day 3 of admission, we found thrombus in the LMCA as well as the LAD. And that was quite scary for us. Troponins were normal, however, and the ECG was also normal, did remarkably well after the initial primary intensification of therapy and the host of anticoagulants, and is now having just a mild dilatation. And this is another child initially seen by Dr. Pal and is also following up with him, and had large giant aneurysms in the LAD as well as the LMCA. So, and also fusiform aneurysm over there in the proximal right coronary artery. So, this is another modified view of the coronaries showing the apical view, and this is the LAD in the interventricular groove. This is a normal size LAD, but slightly dilated maybe, but you can see, appreciate this huge, this is the aorta, and from this aorta, this huge vessel is coming down. This is the dilated LAD and of the giant aneurysm, this bit. This is the aorta with the valve, and this is the giant aneurysm that is coming down in the LAD. And we have to be aware again of, we are not measuring anything else like the pericardial sinuses. Also, we need to look at whether there is coronary veins, because the diseases that are affecting the arteries will be affecting the veins as well. The direction of flow will be different. Osteal stenosis, myocardial bridge, they may be like misinterpreted. And also we have to look for, is there any abnormal origin of the coronary arteries, like the interarterial course and the intramural courses. So, and this is a child again who at around 3 weeks of age only presented with this kind of a narrow stenotic, potentially stenotic lesion at the proximal LMCA, then had dilatation, and also LAD was dilated, shown much better on the CT done by Dr. Singhal in PGI. So just to highlight 2 cases from Professor Shabui sir, and there was this child of 11 years who had come with as a follow-up after 1 week. And initially LAD was mild dilated and everything else went very well clinically. But when I did the echo after 1 week follow-up, there was this large thrombus sitting in the RV. The child had to be readmitted for, again, the anticoagulants. Then did well and it disappeared subsequently. And this is another child of 9 years, came with septicemia, hemodynamically unstable, required inotropes, fluids, had pus aspirated from the joint, had septic arthritis, and this was the LMC and the LAD coronaries. Also had pericardial effusion with strands, and because of the diffusion, we were getting this ST segment elevation globally in the ECG. So this is another child which I was alluding to in the discussion. You see this, there's severe dysfunction as well as MR, possibly because now I realize could be because of the partially torn chordae. And here, this is the RCA, and there is this flow turbulence in the proximal RCA with a fusiform dilatation in the mid RCA. And we can see the ST segment depressions in 2-3 AVF leads, which are actually representing the RV as well. So there's dysfunction and also RCA stenosis, and this is the coronary flow patterns showing high flow reserve and definitely a stenotic lesion. We lost this child to ventricular arrhythmias before we could go for further investigations. And this was the conventional way of assessing the cardiac systolic function, the Simpsons and the M mode. But what I would like to highlight in the follow-up, I think somewhere down the line we need to do the strain pattern. Strain will identify the individual regional wall motions and also the speckle tracking over here, which can be of 3 types. This is the GLS or the global longitudinal strain. We also have the radial and the circumferential strain. But usually in the KD patients, the longitudinal strain is more affected and has been found to be an accurate marker of myocardial involvement. Circumferential strain is not that used. And in this beautiful paper in BMC, they did a long-term follow-up where they found even those without coronary artery disease having a history of KD initially, even they had a significant lower strain. So this is the child with the history of KD with coronary artery involvement, with no coronary artery involvements, and the normal. You see these blue areas are indicating regional wall motion abnormality in these segments of the myocardium. So just to finish off, we need to do some stress testing which can be done by exercise or MRI or SPECT. MRI or SPECT is more of Dr. Singhal's department, so I won't mention those. But exercise stress testing has been found to be very effective in identifying or prioritizing or building up a, identifying those at risk, definitely. So this paper has beautifully given a sort of a practical workflow for the cardiovascular assessment in KD patients. And from Dr. Jane Burns and her team, exercise stress test echocardiography was assessed in children with KD. And even at 14 years, 8 years, or 6 years down the line, they have found these kind of changes in the coronaries. So if a child comes with symptoms, it is very difficult to understand. So unless we are very much aware, we might miss, because the child will be with some ischemic symptoms. They will just be, especially infants, will be irritable, crying, restless, vomiting, and maybe just have breathlessness. So ECG is important to identify, and this is the protocol given for the myocardial infarction in children. The biomarkers will be very helpful to us because cardiac troponin initially rises 3 to 4 hours and then settles down around 2 weeks, 1 to 2 weeks. And serial measurements will be very helpful. And of course, NT-proBNP is an important marker initially in the acute stage, definitely. And from Dr. Pal's study, we have that it is definitely higher in sepsis and other febrile illnesses, but more higher in acute KD. So just to ponder over these points at the end, we need guidelines to identify children who in the long term will be at risk and assess for signs and symptoms in them, detailed echo evaluation, and of course include stress test in the follow-up and go for the point of care tests, the biomarkers, etc. And again, advanced imaging as per guidelines. But I was just wondering, what do we do for the peripheral vessels? Because do we go for pulse Doppler velocities? Because we do not have definite guidelines or even suggestions like what should make us look for the peripheral, assess the peripheral vessels. So with this, I would call upon my next speaker. These are my fangirl moments here. So I'd call upon Dr. Rishika Mehta to discuss the imaging beyond the coronaries. Thank you.
Thank you, ma'am, for the wonderful talk. Most of my points have already been covered, but there are still some points which I would like to highlight. That since morning we have been highlighting on the fact that coronaries, there is something beyond the coronaries in Kawasaki disease. So in order of the frequencies, apart from the coronary artery aneurysms, myocarditis, which is invariably present in 90% of the patients who are almost 80% of time asymptomatic and 20% of times present with LV dysfunctions. Pericarditis with pericardial effusion, though it is rarely reported, but has a lot of importance. Systemic arterial aneurysms, valvular diseases, that is since morning, which has been highlighted on the point that endocarditis is a common manifestation in KD. Mild aortic root dilatations reported in 10% of the cases, and myocardial infarcts. So myocarditis, it is one of the earliest presentation of Kawasaki disease, which presents within the first 10 days of illness, while we start to see the coronary involvement after the 10 days of illness. So when babies present to us with myocarditis in first 10 days of illness, high suspicion of KD is to be there in our mind, and it develops as a result of mostly inflammation of interstitial tissues. So as I said that myocarditis, mostly it is asymptomatic 80% of times, and that's why it's easily missed. And in the other 20% of cases where the patient present to us with unexplained tachycardia, congestive heart failure, hemodynamic instability, and who requires high inotropes and present with arrhythmias with and they cause significant morbidity and mortality if the myocarditis is symptomatic. And there is a thin line of difference between viral myocarditis and KD-associated myocarditis. Patients in a viral myocarditis present to us after following a prodrome, and at the time of presentation, mostly they are afebrile, while in KD-associated myocarditis, patients develop myocarditis early in the phase, and it is accompanied by high-grade fever. And while in KD-associated myocarditis, they usually respond very well to IVIGs, while in viral myocarditis, they poorly respond to IVIGs. What is the role of biomarkers? NT-proBNP has been repeatedly used nowadays for the patients who present to us, and serial measurement of NT-proBNP is very important. So there have been studies where cutoff levels of 1025 of NT-proBNP has been taken care of, and serial measurements of NT-proBNP has been taken care of. And it correlates very positive with C-reactive proteins hypoalbuminemia during the initial phases of disease. And as we know that it has a negative correlation with the LV ejection fractions, fraction shortening, cardiac index, and diastolic function. And cardiac troponins and CPKMB. Troponins have a high specificity and CPKMB has a high sensitivity for this. Pericarditis, as I said, that it is common but underreported, usually mild and not significant. Pericardial effusion, whenever we get a patient of pericardial effusion, we usually suspect a high degree of KD, as if the pericardial effusion increases and it goes towards tamponade, it is usually fatal, because most of the times if cardiac tamponade is present, it may be a component of polyserositis or may follow rupture of coronary artery aneurysm in the pericardial cavity. And mild pericarditis, it often resolves with IVIG and aspirin. So valvular abnormalities, in acute phase, it is integration of pancarditis, but persistent valvular abnormalities due to valvular dysfunctions and pap muscle dysfunctions due to coronary ischemias caused due to myocardial inflammation mainly. And most common abnormality which we always see is mitral regurgitation during the acute phase of KD, which resolves on follow-up. Some patients who develop severe mitral regurgitation, it is due to chordal rupture, and it causes rapid clinical deterioration and usually fatal if not taken care of. Aortic root involvement reported in almost 10% of patients, and root size correlates with coronary diameters but not with the inflammatory parameters. Sometimes patients with severe AR have been recorded to undergo valve replacement later in life because there is an increased stiffness of aorta and decreased in the elasticity, which causes functional impairment of the aorta, and it is observed both during the acute state and the chronic state. So this is the point which I would like to highlight. We usually take care of the ventricular systolic function, but also diastolic dysfunction has been reported. So nowadays with the machines, we can measure the LA strain also, which is a very good marker of the diastolic dysfunctions. And left ventricular systolic dysfunctions, apart from the M mode, we usually go for the speckle tracking images, which is much more sensitive and it comes much more earlier than the decrease in the ejection fractions. So we typically almost always try to do the speckle tracking images in all the patients who present to us with myocarditis. Secondly, regional wall motion abnormalities are obviously a surrogate marker of coronary involvement. And in even those patients who come to us with valvular regurgitation, we typically take care that we always do the speckle tracking images. It has been found that in the apical strain, if it comes down at a lower levels, it is mostly a marker of Kawasaki disease. Aortic root diameters we usually take in the first 10 days, follow up after next 2 months, followed by 6 months till 1 year of age, if everything goes fine. Left atrial stain, as I already insisted upon, diastolic dysfunction has also been reported in cases, so we take care of that. And pericardial effusion we try not to miss. Next, I would call upon Dr. Amber for the further things. Thank you.
Thank you and good evening, everyone. So after an extensive talk by by all my co-speakers, so I will talk about basics only. So coming back to the basics in this session, because in 5 to 7% cases of Kawasaki disease can present with shock syndrome. And looking at the heart rate, blood pressure, and peripheral perfusion is also very important. Otherwise, you can treat like a septic shock in these cases. So, so Kawasaki disease shock syndrome, this is defined as sustained presence of any of the following conditions requiring volume expansion, inotropic agents, or transfer to ICU in a suspected case of KD. So either systolic hypertension for the age, this cutoff is as per the ALS guideline, advanced life support guidelines, or we can use the nomograms also, or decrease in systolic blood pressure from baseline of more than 20%, or clinical signs of poor perfusion regardless of normal blood pressure, like tachycardia, prolonged CFT, cool extremities, diminished pulses, oliguria, and mental status inappropriate to other conditions. So the Kawasaki disease may be the presenting feature in 5 to 7% case patient. This is Western data. We don't have Indian data, and I have searched literature. We could not find any RCTs on this Kawasaki disease shock syndrome. So probably later on we can get the Indian data also. So children with shock presentation appear to be at highest risk of IVIG resistance, coronary artery abnormalities, MR, and prolonged myocardial dysfunction. And they are commonly presenting with elevated CRP, less albumin, and thrombocytopenia compared with the KD without shock. So in such cases, when bacterial cultures are negative and fever persists, the diagnosis of KDSS should be considered. And the shock in these patients with KDSS can be cardiogenic, distributive, or mixed. So this is very important part. So any child presenting with shock and we are suspecting Kawasaki disease in this case, then it can be cardiogenic because of poor myocardial function that we have already seen in our previous sessions. It can be distributive. The distributive component of shock might result from high level of circulating inflammatory cytokines, vascular endothelial growth factors that lead to the capillary leak, and vigorous volume replacement without concomitant anti-inflammatory therapy, that is the IVIG, that is the cornerstone of management, can result in complications from interstitial fluid accumulation. So once we diagnose it's a shock and the underlying cause may be Kawasaki, then first step for the management is to look for the fluid responsiveness. And again, this is the point of care ultrasound, point of care test. We can find out whether the Kawasaki disease shock syndrome, this case, is volume responsive or not. So we all know these are basic tests like IVC collapsibility index and distensibility index. And the recently nowadays we are looking for aortic flow velocity variability and LVOT velocity type integral. These are more sensitive marker for volume responsiveness. So based on these tests, we can decide if the child is volume responsive or not, and then we can manage. The next step is decision on the inotrope. Again, this is important to look for the point of care ultrasound. And we have already seen if the child is hypotensive with no cardiac dysfunction, then we can start any inotrope with pressure support. But suppose hypotension and cardiac dysfunction both are there, and we are starting only pressure support like norepinephrine with very poor beta action or vasopressin, then we are increasing the peripheral resistance in a failing heart. So this is not good. So that part we have to take care with the help of point of care ultrasound available with us. And if in that conditions, we have to add milrinone in these conditions. Now coming to the second point of care test like ECG. So like other atypical presentation of Kawasaki disease, ventricular arrhythmias is also a rare atypical presentation of Kawasaki disease. And if misdiagnosed, the development of aneurysm is increased to around 25%. This is already the same data. And if you see the rhythm abnormalities in case of myocarditis, these are non-specific ST and T changes and low voltage complexes because if there is myocardial edema or pericardial effusion. Inflammation of conduction tissue can lead to any arrhythmias, ventricular arrhythmias or block. Myocardial ischemia can also lead to the any myocarditis and myocardial infarction. So such sign has important role in immediate follow-up imaging and biochemical check in plasma for cardiac enzymes. So the last part, the summary of this hemodynamic assessment, since the Kawasaki disease can manifest before the diagnosis of Kawasaki disease, so it's very essential to recognize the early signs of Kawasaki disease so that IVIG therapy can be initiated promptly, and the treatment of underlying inflammation IVIG and hemodynamic escalation with fluid and inotropic support to tide over the crisis period is important in resolution of KDSS. And role of ECG in KD is limited, but the prompt identification of rhythm disturbances and timely management is crucial in sick patients. Thank you.
you some time. Yes. Speak to the microphone.
One of your slides, you have shown an echocardiographic image where you told about there was a lag dilatation and stenotic lesion in LS. So, I want to know how to care about echocardiography.
It's very difficult, but I think ECG would be a very, very good pointer. But not all stenotic lesions will produce a ECG in the resting child. For that, we need the stenotic lesions. But the answer to a question, if the child is symptomatic also, then also it means that we should go for an ECG and further evaluations. And definitely, I think all children with these kind of, all children with KD on follow-up should have ECG at some point of time, at least at regular intervals. Okay, and because the features are very non-specific. Another point is that if you have an, like I said, if you have a very ideal settings in well-sedated child or a child who's very cooperative, you'll be able to do the coronary flow reserve. So the coronary velocities, a resting high reserve will indicate a stenotic lesion. Ectasia means mild dilatation, like aneurysm will be 2.5 to small aneurysm 2.5 to 5 z-scores. So anything around 2 to 2.5 going slightly borderline cases, those will be ectasias. Okay. No. Pardon? I do not have a number to that, but recently I have seen a few cases with small and moderate aneurysm presenting with junctional rhythm in follow-up, and those junctional rhythms are very infrequent. They are coming 1 or 2 times, a few rhythms are junctional and the rest of the time it's a normal sinus beat. So sometimes we need to keep our mind open and go for a halter also, I think. But that is if you come across these things, and one baseline ECG would be very important, I think. I'll just make a comment over there. How old was the child? Sometimes in newborns or infants you have the atrial ectopic tachycardia. That is very similar to the sinus tachycardia, but the rates are very high. It is from an ectopic focus which is very close to the normal sinus node. So if you have that, it's very difficult to differentiate from the normal sinus rhythm, excepting for the fact that the rates will be consistently high, like 190, not variable. That is the thing, is that in those cases you have to use beta blockers, may use amiodarone, but mostly it responds to ivabradine. Ivabradine is being used very commonly for those. But yeah, probably because of Dr. Amber mentioned about the inflammation bit of the.
So that was the right hand. That was the right hand. Definitely. Other things are okay with
So, sir, just one comment. Myocarditis is basically the inflammation of myocardium. So that will lead to the ST and T changes. So baseline ECG is important to differentiate ST and T changes. And the next is, if myocardium is inflamed then and edematous, then it can lead to the low voltage complexes. Otherwise, low voltage complexes are more common in pericardial effusion. Now coming back to the tachycardias, if the heart rate is more than 220 in an infant, then we can consider it as a SVT, but we have to look for whether RR interval is fixed or not. If RR interval is fixed and it's not responding, even on stimulating the child, the interval is not changing, then it most likely towards SVT than normal sinus tachycardia.
One thing is that as far as the function is concerned, if we can do a strain properly, it would give us, and if there is any regional wall motion abnormality, that can give a fair idea, but it is very difficult to differentiate. And about the valvular regurgitation bit, if there is, like we have a severe MR or moderate to severe MR, if there is partial tearing of the cordae. And I think Dr. Sudha can give you from her vast experience, she can give you more information, and Dr. Chattopadhyay wants to add.
Probably what you asking probably that whether you can understand the grade of myocardial involvement by the echocardiography alone, if I have interpreted the question correctly. So what Dr. Devdutt is telling, there are two major modalities of treatment, echocardiogram. One is the 2D, where we have mentioned is the regional wall motion abnormality, which you can see just upon on the screen. So when the regional wall motion abnormalities are already present, that means there has been some good amount of coronary involvement. But apart from that, there might be subtle amount of myocarditis or even myocardial ischemia ongoing, which can only be captured if you do the stress and strain imaging. So to capture those at very early stages, probably you will need a stress and strain imaging. And what is the practical utility? Practical utility is, would there be any difference in treatment which you are already doing? Because what Priyankar was telling is that the major modality of treatment is the IVIG and the corticosteroids and the other anti-inflammatory medications. Most of the symptoms and the major manifestations come down with the decrease of the inflammation itself. Like even the tachycardia or arrhythmias will come down with that one. But if it persists, then what to do? There, you have to escalate your myocardial therapy. If there is dysfunction, you go on increasing the inotropes. Obviously, one thing we have to remember is any inotropic therapy, by virtue of its nature, any inotrope will increase the myocardial oxygen demand, cellular oxygen demand. So they are also detrimental. So we have to maintain a balance. I think doctor told, one of the speakers told about the milrinone. So adrenaline, noradrenaline, or even milrinone to reduce there should be a perfect balance with the preload, afterload, myocardial contractility, and obviously the myocardial perfusion as well, which you maintain with the antiplatelet and anticoagulants.
And, thank you, sir. And I think we must remember that all these inotropes can increase the stress on the coronaries as well, because they will be increasing the oxygen demand on the heart. And all these will be pro-arrhythmogenic, most of them also. So it's a very delicate balance which inotrope to give in which condition. Thank you.
Thank you, speakers. So we move on to the next session.
For the next session, that is limitations of echocardiography for the assessment of coronary arteries in KD, may I request Professor Sujit Singh sir to please chair the session.
So in this session we have two speakers. So we'll start with Rakesh first.
किसमें है? पेनड्राइव लगाया मैंने.
ये खोलो.
Kawasaki.
हाँ Kawasaki.
PowerPoint है.
हाँ PowerPoint है नीचे.
किसी फोल्डर में है.
न्यू माइक्रोसॉफ्ट PowerPoint है उसका नाम, फोल्डर का नाम न्यू माइक्रोसॉफ्ट. ये
ब्लैंक है क्या पहले?
So good evening all. Again, so after discussing the echocardiography, that point of care echocardiography, we should also know that what are the limitations of echocardiography, and because that is also very important, and me and Dr. Amitabha will be discussing that what are the limitations. I will be just discussing the limitation part, and there will be real life scenarios by Dr. Amitabha, and why it is important to know that what are the limitations and when should we go beyond the echocardiography. So the role of echocardiography is that its importance of assessing coronary artery involvement, and it's a first line imaging tool, and it will be used commonly, and it will be used first line, and it will be used more frequently because of the nature of availability, and it will be used for serial monitoring, and it's safe, non-invasive, and widely available, and there are no side effects available or no radiation exposure as seen in several other modalities. So, but the major limitations of echocardiographies are that it's limited visualization of distal coronary arteries and left circumflex, and we have seen multiple times that you can't see distal coronary arteries very well in echocardiography, and almost most of the time seeing a left circumflex especially in older children is very difficult in echocardiography. And second thing is operator dependency, and more so in children, because in young children doing echocardiography, it's again require a lot of skill, and it's more of patience rather. And then inability to assess the coronary artery stenosis or thrombosis, because many times say that it's a stenotic lesions, it's a difficult thing in echocardiography, and you have to perform several other imaging, and there are challenges in older children or obese patients because you may not be able to get a appropriate window. So the limited visualization of distal coronary arteries is because echo is very good for proximal segments, and the distal coronary arteries and branches are often very poorly visualized, and it is because of the interference from the lung and rib artifacts, and possibly you can't see the distal coronary aneurysms, distal coronary segments in all patients. Sometimes you can see in several other views which will be discussed by Dr. Amitabha. And that there are and then second point is that because you may be able to see the proximal aneurysms, but sometimes we can't see the distal extent of the same aneurysms, because it's also important that we have to see the extent of that aneurysms, and sometimes one coronary artery can have several aneurysms. So if there are several 2 to 3 aneurysms, these will be the complex aneurysms, and visualization and detailed visualization is essential. In that, echocardiography may fail actually. So transition to normal size coronary arteries, and it may estimate the true burden of the disease because of the Kawasaki disease. So we have shown previously that the distal coronary artery abnormalities in Kawasaki disease can seen, and it's because the usual conventional thing is that KD involve proximal segments only, but it has been shown that the distal coronary artery abnormalities can be seen in KD, and sometimes they can seen in isolation, because in isolation in the sense that proximal coronary artery may have resolved at that time, or typically just a distal coronary artery aneurysms was there, and these coronary abnormalities may not be able to pick in echocardiography, and these settings there is a role of further imagings. Limitation in assessing the left circumflex coronary arteries, because L6 is often difficult to visualize in echo, and because it's located posteriorly and hidden behind the heart, and there are several aberrations also, and because of this, in standard parasternal and apical views do not provide the clear imaging. Sometimes there are acute angle branching of the LMCAs, and at that time you may not be able to see the L6, and you may miss the aneurysms in L6 altogether in some patients with the Kawasaki disease. So again, there is a value of further imaging like CT coronary angiogram, and we have shown previously that if you do CT coronary angiography in these patients, you may identify several other aneurysms which were not detected on echocardiography, and which have been missed altogether in the patients with Kawasaki disease. And sometimes, like in this study, we have shown that 4 out of 37 patients with Kawasaki disease had isolated LCX involvement. And if you will not do the detailed imaging, possibly you miss those coronary segments. Again, the challenges in older children, which have already highlighted, because the visualization of coronary artery becomes progressively more difficult as child grow, and the thicker chest wall, and there are suboptimal windows, and it may require alternative imaging. So whenever we, typically the age beyond 8 to 9 years of age, and sometimes obese children, you may not be able to get an appropriate window with echocardiography, and in that situations, the echo has several limitations in assessing the coronary artery abnormalities. So echocardiography can be hindered by several artifacts, particularly in obese patients or those with tachypnea, which can further obscure the views of coronary arteries. So limitation of in identifying the coronary artery thrombosis and stenosis again has been shown by Dr. Devadatta also, that you may see that there are several views that in one of the patients he has shown that it looks like a stenotic lesions, but further when we did the CT coronary angiography in that patient, there was no stenosis. So it has to be confirmed by further imaging. So echo is not foolproof in identifying the stenotic lesions. So sometimes when you are treating Kawasaki disease and you are looking for coronary artery abnormalities, and you are doing echocardiography and you may miss congenital malformation and misdiagnosed as a coronary artery abnormalities. So because congenital aberrations and congenital anomalies are also there, and one of the patients we have seen that the infant came with the fever and like all the signs of Kawasaki disease, and the infant had a significant myocardial dysfunction, but that myocardial dysfunction has not improved with IVIG completely, and that baby had L kappa at that time. So it's possibly that we are dealing with congenital malformations, and if you are looking for the coronary artery abnormalities in echocardiography in a Kawasaki disease, possibly you are not looking for those L kappa and all these things. So in that situations, if there are congenital anomalies, it may be missed, or it may be like understated in that case. So this is a study from Teko group, which is also preferred the CT coronary angiography in Kawasaki disease, and they have shown that echocardiography underestimate the coronary artery abnormalities in and if you can see that these were the coronary artery abnormalities which were completely missed in echocardiography, and which has been detected by CT angiography. So echocardiography is a first line but has limitations, and we should know what are the limitations, wherever we have to escalate or where we have to go beyond the echocardiography, and other imaging modalities are needed, especially in high risk patients or where we have to do a detailed coronary artery assessment. So there are importance of multimodal imaging approach for optimal coronary artery assessments. So further, I would invite Dr. Amitabh Chattopadhyay, and we'll take a question after that.
Good evening, everyone. So limitations of echocardiography. So there are obviously, it's time, I think it's almost 5:30, the IPL session, opening session is going on. So as in a cricket team, you all know that we do not have all the all-rounders. We have a specialist batsman, we have specialist spinners, and obviously we have fast bowlers. We have to have a mix and match. So the patient and the doctor both have to be patient. We'll be inspecting structures measuring 2 to 3 millimeters. Obviously, one of the main things which we are forgetting is we are inspecting a heart which is beating at a rate of 120, and with crying it is at 150. So imagine a bowler bowling at a speed of 140 and a batsman without a helmet facing it, just like Sunil Gavaskar. So we have a cranky child. Usually they remain irritable with the fever and the associated illness, and we have this position. So the doctor is positioned either like this or maybe like this. So the machine, the knobology, and the person behind the machine. I'm going to talk about the echocardiographic portion. So again, a heart racing at about 150, and आजकल तो IPL में भी 5-6 एम्पायर रहते हैं. पहले 2 एम्पायर रहते थे. Yes, now we have 2 specialized umpires sitting on the TV and 3 specialized umpires on the ground. So we have to utilize the best of the machinery and the best of the machines which we have. Obviously, we have to select the probe, a proper probe, a finer probe with a higher frequency and a proper frame rate. We have to increase the frame rate as high as possible. Just like in the CT scan, if we do the CT, which sir is telling that if we do the CT at the 64 slice, the most of the information will not be available. So we have to keep pace with the heart rate, and obviously the rate at which the heart is beating. So minimal is 128, 256 is for the better. Proper depth and sector width. We have to increase the depth or optimize the depth in such a level so that the coronary arteries are brought just to the surface, turn the patient and baby to the left as much as possible unless there is a dextrocardia, and the sector width has to be minimized so that the best of all the pixels are concentrated on the same phase and the best of the pictures is brought out. We can adjust the contrast or the compression, as Deepta was telling, to bring in a crisp image and reduce the artifacts as much as possible by using all the knobs whichever is feasible. So this is a knobology. I have got a comparison of two pictures. The same picture on the right side, you have the same picture. On the right side, on the left side, you have the same picture, but all the knobs have been adjusted. You can see the coronaries are almost standing out. But in the picture on the left, the coronaries are almost subdued, so that the rough assessment is done. So assessment of the coronary arteries. Measure after a magnification. We can zoom it before that one. Otherwise, just like whether the batsman is run out or not, we have to make it in slow motion, and we see it in several number of times. Inner edge to inner edge, perivascular cuffing, which is subjective. So the perivascular cuffing is not actually included into these dimensions. Don't measure the bifurcations and take multiple views as much as possible. Now take multiple views, there's one point worth it. Suppose we measure plenty of patients, because one of the relatives once told me, the doctor साहब क्या किया आपने पिछले बार 2.3 मापा था, अभी 2.6 है, 3 महीने हो गया, क्या दवाई दी है, कुछ तो कुछ नहीं हुआ. So this is a practical experience which I am telling. Plenty of parents, they feel that 2.3 and 2.6 does make a huge difference in life. It is very difficult to explain them practically, because 2.3 and 2.6 won't make much of a difference. But what we do is, suppose the same observer at the same setting takes 3 measurements, and I bet they won't be equal. So we try to average it out at different positions, multiple views and multiple postures. So as you can see, difficulty in visualizing the coronary is too small or maybe included, and they are moving. So there are turns and bends. We have to see whether clots inside and to make crucial decisions. Like this is a crucial decision, batsman is not out. It's very unlucky. The ball did hit the wicket, but the bell did not fall. So appreciation and measurement of aneurysmal segments, serial measurements, and standardization Z-scores, preferably by the same observer, but sometimes it may not be possible. Suppose the same patient comes again and again, and in the OPD, we have one echocardiography in one instance, and we have another echocardiography in another instance. So delineate the branches very quickly. This is just an example. See, the heart is beating at about 130 per minute. I don't have the ECG here. And this frame has been stopped, and the frame on the right side has been derived. So this is a full motion, and this is in a still picture which has been derived from the motion. And obviously it depends on the observer bias, and obviously at the frame rate and the frame which you are choosing. So aim and shoot. So you can see the left coronary artery aneurysm, the same thing, we have stopped, and we have measured the aneurysm in 2 different views, 2 different dimensions. So perivascular cuffing. See, perivascular cuffing is quite subjective. Obviously, on the first frame, you see there is a good amount of perivascular cuffing, which is some amount of tissue which has been adhered. And on the second picture, you can see there is a small aneurysm just after the bifurcation, followed by the LAD. So this is the cardiac function. When we assess the cardiac function, this is a myocarditis associated with Kawasaki disease, dilated, and the function is subdued. On the right side, we have a good cardiac function, so the function has not been affected as of now. Pericardial effusion. Obviously, pericardial effusion is rare, but you do get it at some times. And turns and bends. As you can see, this picture was taken by me a long time back. As we stand on the Nadi Kinare, and on the banks of the river, we can see only a forthcoming, we can see only up till Sunday, certain extent. And this is normal coronary distribution. Obviously, the coronaries navigate all around the heart, and obviously it's not possible for us to see beyond a certain limitation of the coronary arteries. Luckily, as my previous speaker said, very luckily, maybe the creator also listened to us, that most of the coronary aneurysms occur almost 80 to 90% within the first almost 1/3. So what happens to the distal ones? To see them, obviously, we need either a circumnavigate echocardiogram, which is yet to come, or maybe we have to take help of some other digital mode. So this is a valvular regurgitation with some amount of dysfunction, and on the right frame, you have some amount of dysfunction associated with some amount of mitral regurgitation. And delineate the right and the left coronary systems. So as you can see, these are all the still pictures. This is the boy which I was telling in the afternoon. There's a huge giant aneurysm which is totally occluded by a huge thrombus. So he presented with a myocardial infarction, and he came to us with a giant aneurysm, totally occluded with a thrombus. So as we can often say, that if you do not see the coronary arteries in a very small thing, see just now, Dr. Deepta was mentioning that how to understand the stenosis. The structure already is 2 millimeters, and even a small infant, it might be 1.5 millimeter. उसको ऊपर stenosis किया. So what happens if there is really a stenosis? It's extremely difficult to find the flow, but definitely we can invite some other things. So you can use the colorization judiciously. We can use different forms of color on the echocardiogram to bring out the contrast as much as possible. For example, in the blue picture, you can see the echocardiogram is much more, the coronaries are much more standing out, and on the left, in the sepia color, you can see. So check from all angles. As you can see, on the first frame, the left coronary artery is actually not seen. We are seeing the right coronary artery. Whereas on the left frame, you can see the right coronary is not seen, but the left coronary artery is seen along with the small aneurysms, which should not be missed. So check the flows. Obviously, even when you delineate the arteries, we have to check the flows. This is the posterior descending artery, as you can see in the first frame, and here you can see in the left coronary artery, there is an aneurysm, and the coronary artery flow was seen just beside it. We have an aneurysm on both the systems, at the right and the left. So here, how do we compare? Now the Z-scores and other measurements come to this thing. Pediatric multisystem inflammatory syndrome, temporal associated COVID-19. I think we have discussed with the coronaries. One passing remark about this one, because most of the coronary abnormalities which we saw during that phase, that particular phase, were very quick to disappear, very quick. Perhaps the pathophysiology and the anatomical landmarks were slightly different from this one. You might be able to tell more precisely. So this is the detection and management of coronary thrombosis. One of the main confusions which happens is that often we see thrombus inside the dilated segments. Now whether it is really a thrombus or whether it is something else, because the management would be totally different. In the first frame, you see there is a coronary artery aneurysm involving the LMCA, part of the LAD and the distal LAD, and obviously the circumference also appears to be slightly bigger. In the second frame, you see this was taken on day 2. There was a large thrombus sitting there. It was very difficult to believe. This was a 1.5 months old baby who has been diagnosed with Kawasaki, and we saw this on the day 2. And definitely we gave her the management, and the clot also disappeared. But sometimes it might be, as Dr. Devda was telling, it might be pericardial folds overlapping in such a way as if mimicking the coronary. But at the same time, it's difficult not to treat this child, because otherwise it might be playing with life. Giant aneurysm with clot inside. This is the child which I was telling in question. He underwent a CABG, and this is, I just thought I would include the coronary angiograms of that particular child. This is a aortic root angiogram where you can see that the right coronary artery is totally seen, but the left coronary artery is not seen at all because it is totally occluded, and it was being supplied retrogradely by the collaterals. In fact, we planned an OCT for this child, but it was impossible because the probe could not be inserted into the left main coronary artery. These are the distal aneurysms. This was a child, he's an engineer now. He came to, this is a long time back. This angiogram was done by Dr. Vikas Kohli in Arctics. And this was the distal aneurysm, and it was difficult to see on echocardiogram. You can see the proximal coronaries are completely normal. And it was the distal aneurysm which was extremely deep, and it was not seen on the coronary echocardiogram. So this comes to the end of my talk. So believe nothing, no matter where you read it or who has said it, not even I have said it, unless it agrees with your own reason and your own common sense. This is a picture from our city, the city where we come from. Thank you.
Okay, thank you, Dr. Amitabh. So,
Thank you, sir.
Three very experienced pediatric cardiologists in the hall today. It's not often that this hall has such eminent cardiologists, so Dr. Sadi Philip, Dr. Amitabh, and Dr. Devdatta. So, do you have any comments on the presentation that we just made? Sadi first.
Yeah, I think you can hear my voice. Definitely echocardiography is operatively recurring. But for pediatric cardiologists, I don't think much limitation for echocardiography except the peripheral the areas and circumflex arteries may not visible. But of course, the echocardiography can identify many associated findings like early valvular regurgitation, like AR, MR, and flaggy chordae that indicates that chordal rupture. Whereas local LV, if you are seeing with MR, definitely led to the LV dysfunction. And the papillary muscle rupture, definitely it is due to coronary artery disease. Whereas caudate rupture, definitely it is in acute phase due to the immune complex definitely attacking the caudate. Because caudate consists of collagen and the fibrous component, elastin. So this is really interesting that as Dr. Sudhir Singh said, it's definitely described as pancarditis. We are seeing pericardial involvement, myocardium, but whereas endocardium is not much observed in our experiences. Whereas valve and cord is involved because of that, because the elastin and collagen is much affected for the circulating immune complexes. So ECG definitely will help. That means the initial stage 1, 2, 3 ECG changes in the pericardium. Stage 1 is actually PR level sagging and ST segment is M pattern. So that easily can identify. So as soon as child is admitted in the ward and suspected grade, you have to take an ECG because many cases referred to us without ECG they are coming. So ECG will give at least we can identify the pericarditis. So the involvement of the valve and the pericardial lesion and the LV dysfunction definitely we can correlate with the like 2 criteria plus coronary involvement previously we said we can put it as incomplete KD 3/5 like that. But whereas even though coronary is not involved, valvulitis and pericardial efficiency if you are seeing, definitely you have to consider as a KD and start treatment. Thank you.
Thank you. I think for some amongst the audience they may not know, Dr. Saji has almost 3 decades of experience managing these patients, and he's the founder of the Kawasaki Disease Foundation of India. So he's a person who was primarily responsible for organizing the biennial Kawasaki Disease summits in India, and it were these summits which ultimately took the shape of annual Kawasaki Disease conferences. So please.
Sir, I have a question for sir. Sir, myocarditis is very common in KD, and most of the patient has myocarditis presentation. We don't treat with other treatment. We don't intensify our treatment as such for myocarditis, but any guideline for pericarditis if it is coming in severe, when identified, besides IDH?
Most of the pericarditis will subside its own like a natural course. Whereas myocarditis involved, definitely I will correlate with N-proBNP and proBNP. In our situation, lab parameters may change. Because of that, I used to repeat once again N-proBNP next day. Whenever you see a rising kind of N-proBNP, definitely age is concerning. The normal values in the neonatal age is very high, 3,000. It's normal. Whereas 3 to 5 years, above 350 microgram is significant. So, correlating with the N-proBNP, you consider as myocarditis. Then EF is low, definitely I will address for IAE. If the EF is maintained, then neither prednisone I used to address in the general cases. Kawasaki disease anyway, definitely we are adding up this myocarditis plus other 2 criteria. Definitely we are starting on IDA. And pericarditis, usually you won't do anything. Natural way of suspicion is there. IDA and anti-inflammatory treatment is there now.
Yeah.
So while dealing with myocarditis, I will ask your opinion. In the case of very confused about that very common shock, usually incompetent high current markers, they land up in the PICU. Majority of the times they start seeing a shock. So what is the clinical pointers that say that along the septic shock in the areas?
Well, our experience is equally sad because once the baby enters the PICU, they hold the reins and they hold their reins very tightly. So you have to convince them that if the child is not improving in spite of antimicrobials and if the blood cultures are repeatedly coming sterile, you have to rethink. And it's all the subtle signs of KD in such a situation. The suggestion of redness of the lips or of the tongue, look at the BCG scar, look for the dilatation of the gallbladder, look for the overall clinical presentation, extreme irritability. It will be these very soft signs which sometimes tilt the balance. But intensivists being intensivists, it's not easy convincing them. So our senior residents, they have had their fair share of fights with their senior residents. But sometimes they agree, yes, and if it is KD shock syndrome, the response to intravenous immunoglobulin is dramatic. This is completely dramatic. It's a different child that you see the next day. So this is maybe one of the senior residents can chip in. Arjun?
The clues that I would say that in higher cardiac associated shock, fever is almost on the fever is not that prominent, but in KD shock fever will be prominent. So this is one feature. In overall clinical picture, as I have told, and other the echocardiography, bedside echocardiography that we do. And the pro-BNP sometimes gets intermittent pro-BNP as a biomarker of, which is not that elevated in septic shock, but in KD myocarditis associated shock, it may help.
In 2018, we had Dr. Najib Dada delivering an oration on KD shock syndrome, and we had the entire PICU team here in this hall. He tried convincing them, they went unconvinced. So they are a very resistant lot, very resistant lot. Okay, Dr. Devdutt. No, the question is, were you able to convince your ICU colleagues? That is a question. Yeah, so breathe.
So you told that pro-BNP is very high. So that if you tell that pro-BNP is a marker of Kawasaki disease to the ICU people, they will not agree. They will tell it is due to the ADI, it is due to shock.
But actually, we have done a study at
One study from here also that the cutoff of NT-proBNP.
So we saw NT-proBNP in KD patients as well as in patients with other febrile illnesses, including patients in PICU with shock or sepsis. So some of the patients with shock and sepsis are very high in inflammation. But what we found that KD patients are the more uniform and overall the median value was high. So that's what we found. But individually, if you see, some of the patients we have very high.
Dr. Mita.
After I have a comment to make in the under the circumstances which you are describing, often the pediatric cardiologist is called upon to act as a judge. And it's extremely, because it is in between, it's extremely difficult to convince both the ends that whether it is Kawasaki or not. So I will.
I would be getting tested for the last 30 years. And my journey started from PGI under Dr. Singh and Dr. Jayashree. I just want to mention here that we are the most malleable ones. Because what I was practicing 20 years back, regular suction, changing the circuits, doing the castrol change, changing the central lines, we are no longer doing those things. But we are very, very scientific people. Once we have confirmed hard evidence, we are the first one to change ourselves. So maybe I'm looking getting tested. So during COVID times, we saw many patients. And during that time, we had to use steroids and all that. So we are taking pro-DMP very, very, we are also presenting a paper. KD is a real threat, and unfortunate part is that patient starts sometimes clinically improving. Very high CRP, you think it's an infection, clinical enteric. Patients on 4th, 5th day starts improving. The CRP falls from 300 to 40, you are happy. But the platelets are now more than 10 lakh. Rest everything is fine, no history of definite rash. And just out of instinct and out of seeing so many patients on KD, we said, so let's repeat the echo. And within that 1 week, echo is done on day 1 and then discharge, and within 7 days, the echo shows coronary dilatation. So that's a bit challenging and bit scary situation that we may be missing many atypical cases. And nowadays, the children are dying on the grounds playing. So I mean, we are going to get a room of myocardial ischemia. It's a scary disease. And we are very 27, 20, in Neo Heart Center in DMC. 27 years old child, I would call him young adult, coming with diffuse coronary artery disease. They say we cannot do stent. So we do not know why there is such a diffuse coronary involvement in such young people. So maybe the child had a history of high-grade fever in the past, which was missed. Still we get children who are given meropenem, vancomycin. Since CRP is rising, they go to polystyrene, polymyxin, but nobody thinks of it. So I think this is a one thing which we should give advertisement in TV like we give for Delhi. That for pediatricians don't know how to diagnose KD. So it's very, very sad situation. We stop all antibiotics, but by the 3rd week the child already has aneurysm. So I think we should go to the field and tell more pediatricians at the peripheries that please don't hike up antibiotics. If all cultures are negative, suspect KD as the primary diagnosis, especially with high CRP and high platelets.
Thank you, ma'am. I'm sorry, I forgot that you were sitting in the audience. My sincere apologies. Professor Puneet Aulak is a very senior colleague. She heads the Department of Pediatrics at the Dayanand Medical College in Ludhiana. So I wish all intensivists were like you, but they aren't. Dr. Mehta.
Sir, I have a question for you, sir. So, like prior to the early intensification of therapy, like those children who had a giant aneurysm or maybe aneurysmal coronary arteries, so what was the incidence that they used to come back to normalcy, or they were just followed up, they maintained that diameter and all these things? Long-term follow-up.
Many of them, yes, continue to have abnormalities.
Okay, was there any, did the diameters come down over a longer period of time, like 5 years?
We have to check the records, but in many of them the diameters did not come down before we started on the very aggressive intensification.
We have data from Japan and Canada on these long-term outcomes of patients who had a small aneurysm, moderate and giant aneurysms. So if you take giant aneurysms, one cohort is from this again Toronto. They followed up for I think 10 years, and one they have from Japan from 1996. So if you see the long-term cohorts, 50% of them may go for a regression over a period of time in giant aneurysms. Around 94% 5% to 90% of them moderate also go for a regression. Small aneurysms were never been a concern. They go for a normalization and maybe in
we have a similar result. We have a cohort of about 30 patients whom we have followed up over a period of 10 years. So most of them, as you said, the giant aneurysms, they remain so. Most of them have been remained so, but till now they have not formed any strictures just after the aneurysms. The medium ones and the smaller ones, mostly they have gone back to their normal.
I think his specific question was, were the regression rates much less when the therapy was not that aggressive?
There is one study published recently from Japanese experience, and they have shown that the children who are treated recently, in recent years, have chances of their regressions are higher. So that means that possibly they are using more treatment intensification recently. They have implicated and concluded their study in that. But they have not looked into the specifically that whether they have used, but what they have shown is that when children who were developed in last decade had chances of regressions are higher rather than who have been treated previously. So there is a possibly relation that
this therapy is actually helpful.
Because we are using treatment intensification in last 10-15 years only, or possibly more last decades only.
Yeah, treatment intensification definitely will matter. I remember one abstract from Dr. Devapal regarding the infliximab and the follow-up of the Daniel. There was a much regression with infliximab rather IAE.
Over there we saw that earlier you get the infliximab actually, that also mattered. So the earlier intensification was done, so that actually mattered in the long run. So initially because we were also a little skeptical and our colleagues were skeptical, so infliximab was sometimes delayed. So now we give more proactively.
I have a question that in KDS, IAE, most of the KDS cases, IAEs are resistant. So such cases, can we think first line itself as the infliximab for KDS?
I think we have been using more of steroids in such a situation, but infliximab also we have given, but I don't have the exact data. I don't think we have analyzed that data yet. But usually you would give something more than IVA. So I think now it's time to move on to the last session of the day. And this is to be given by Professor Suda. And this is on assessment of cardiovascular risk in children with KD. So this is a very, very important topic because on the bedside,